do, let's say, some experiences, but to my patients here in my clinic, I cannot take a risk, and I know that they accept autogenous bone, without a problem. So everybody knows people are coming, but I can offer them really 100% safe result. This is more important. So other methods, I have no experience, and the problem is here. I said already before, when we are working with GBR, it's a totally different concept. So we have another attachment of the periosteum on these materials. It's foreign body. The body usually wants to get rid of it. It's not that natural approach like we are knowing it from working with the real patient's own bone and soft tissues.
Thank you, Frank. What you said during your presentation left an impact on me. You said, don't mix and match. You can't take concepts of conventional GBR, and you didn't say anything bad about GBR. You pointed out very academically and in a very balanced way what is good about GBR and how does it compare to biologic bone augmentation. You didn't what we call poo-poo it or said something bad. Obviously, we all here on a journey of learning and mastering what we do. But you were very clear about the fact that we shouldn't mix and match. Don't do a BBA approach or biologic bone augmentation and start adding membrane and limit the potential of bone induction. So I think that's a very valuable bone augmentation, and you demystified it. You created almost like a formula for success. Doesn't mean we don't have to think anymore. Doesn't mean we don't have to use our brain. But you created a certain formula that has worked for you in very high success course in July. I'm super excited about that myself. First of all, to meet you in person. I was looking forward to that, although I feel that I know you already. But it will be so much fun to spend a full 3 days from the morning through the afternoon, where we do hands-on training with you, all the way to the evening, where we do our soft tissue mastermind. So we'll be sitting in a beautiful restaurant with all the doctors, and we're going to brainstorm together what is the ultimate bone graft. What is the, let's call it elite bone. What is the elite bone grafting augmentation technique? And we know that it's not just about the bone. Bone needs to be vascularized. So there are a lot of soft tissue tips and tricks and wisdom that you're going to be sharing with us. So I'm excited about that.
Absolutely. I can just really underline that it's not only in the classroom. It's actually sometimes just the coffee break, or like you said, during the dinner, where you're exchanging, where you're socializing, where you're it's also for networking, meeting new friends, and I really appreciate that a lot. That it's not only a lecture and then going. It's really staying these 3 days together and having a wonderful time together. And I'm really looking forward also to meet you in person and to see you in Beverly Hills. Amazing.
Excellent. And this is why Rashad created the code that will give you a discount. It's a coupon code. And we could have just written down 10%. We could have written down just 10 discount. But we call this coupon code Elite Bone because this is an elite course, and this is a technique and a philosophy and a movement that will teach doctors in attendance how to create real bone, and the real bone is the elite. And I have to be honest, for many years I've been utilizing all sorts of techniques, all sorts of bone augmentation. And I wanted to share with Frank a photograph. Is it okay to share with you a picture and give you my opinion?
Please.
Okay, excellent. I wanted to show you one picture. Let's see if I have it here. Here's a bone. Actually, I need to share that. Just a second. This is also broadcast right now on YouTube Live. Okay, can you see this bone graft?
Yes.
Excellent. So this is a corticocancellous bone graft that I did a couple of years ago. You can see the double fixation, you can see the trimming, but it is one of those white blocks. Now I wanted to share with you what happened in the during the placement. Let's see. At the time of placement. Let's stop the share for a second and let's share again. Okay, so I wanted to show you an outline. This is where the fixation screw was. Can you see this little
Yes.
bump of bone? So the block graft actually was all of this thickness. It retained some of the bone around the fixation screw, but the rest was resorbed. Why is this happening? Why do block grafts resorb almost 50% in the first couple of months?
So where did you harvest the bone?
It was a mandibular symphysis block graft. Let me show you the harvest. Okay, I'm going to just share with you one more photo, and thank you for the feedback. Okay, so here it is. Look at this. Look at the size of this block from the mandibular symphysis. Please give me your honest opinion and criticism about, what is the difference between this type of corticocancellous bone graft and the bone plates that you demonstrated so nicely during your presentation, and what you will be teaching us, because I think this is just a mindset shift, and this is a source of a lot of confusion to a lot of doctors that are thinking about bone blocks versus bone plates, and not just the mechanical but also biologically. So give us a couple of pointers about this type of graft, and I'm looking forward.
Absolutely. So first of all, it's really awesome. So you're also autogenous guy. That's wonderful. So because also taking bone from the symphysis is quite hard. So I'm telling you why. So you remember the defects forms I showed you. So when we differ between inside and outside the contour defects, we also differ between inside and outside the contour structures. And here, usually at the chin, it's usually almost sometimes a concave structure. So at least it's much more inside the contour when you compare it to this nice balcony, which you're usually having at the external oblique line. So alone the harvesting is much more invasive and more difficult than when you're going for the external oblique line. The material itself is quite similar. So what there is preferable, sometimes you have like a curvature from the chin, but you can also take more cancellous bone. So I don't say that chin is wrong. So if it's the right indication, maybe in 5% of the case, we're also going for a chin. But so we prefer in 95% of the cases external oblique line. So, but like you said already before, so the difference is mainly laying in the way how we are modifying the block. So we are cutting it, we are splitting it, we are scraping it, we are thinning it, we are enlarging the surface, and this makes the actual difference. When I remember how you fix the plate, maybe instead of fixing it, how do you say, you could have fixed it more in a landscape position, so not in a vertical position, more in a horizontal position. So I would have changed this a little bit. Then you were very close to the surface of the neighboring tooth. So this is also one of our rules. We should never touch the surface of a neighboring tooth, because this can also, via the pockets in the neighboring tooth, they can come, some saliva bacteria can cause again some resorption, or even it can even cause the loss of the full transplant. You put particles around the block. That means also sometimes people are putting particles on the block, which makes not too much sense, because it's outside the contour. Outside the contour, you have muscle activity. That means you will have a resorption of all these particles. Sometimes people are also, maybe 2 or 3 threads are exposed. They are just putting some autogenous bone particles on these threads, condense it, and hope that it will stay stable. But when you are having a closer look to the CCLD classification, you will see that here, this is not indicated outside the contour. Also here, the bone chips will resolve when you're not stabilizing them. Yeah, so these are just small things. And you see here the full cortical block, which probably takes too much time until we have a revascularization, which can lead then to some more resorption than we are knowing it with the BBA concept.
Excellent. So, when you said small words, these are big words, and this is great advice, because the way I was trained was to overgraft and cover this block graft with particulate bone and cover all the voids and make some perforations inside the bone and things like that. And not to our surprise, or not to your surprise, 50% of this block graft was resorbed at the time of implant placement. And who knows what happens what happens later on.
Absolutely. When resorption starts, also from a sharp angle, or when you put in the particles, then you're starting a resorption process in that area. That means you're activating macrophages and osteoclasts, and usually this stops first after a while. And try not to start this resorption process. This is also one more reason why we should never, for example, mix biological bone augmentation. I hear echo. I don't know if you also hear it. So that means should not cover the bone augmentation with the membrane, because when the membrane resorbs, it's also starting resorption.
Rashad, you want to mute yourself, Rashad? Rashad, mute yourself. No, just mute Zoom. Mute Zoom. I think we're good here. There you go.
Okay, perfect.
Much better.
No membrane, no collagen membrane on biological bone augmentation, because why is it resolvable? Because it resolves, and that means macrophages and osteoclasts are activated, and we don't want that in that area, because they are, autogenous bone particles are very, how to say, so osteoclasts like autogenous bone particles. Yeah. They're very delicious for them. That's what the word I was looking for.
They're so delicious, like the dinner we're going to have in Beverly Hills, the same way.
Exactly.
Excellent, excellent. So the registration for the our elite course is now open. To register for this training, go to surgicalmastercourse.com and make sure to use the coupon code Elite Bone, and then the price will be reduced from $7,500. It's a very significant course, with a significant price. But if you think about the value that you're getting from this course, and if you learn one technique or two techniques that you can immediately implement, your investment is returned tenfold. So having said that, add the coupon code Elite Bone, and the price reduction is going to show up. Register. We have a secure checkout page. We accept all types of credit cards. Make sure to take advantage of joining the course before March 31st, because then we'll have a price increase. I believe, let's see. Yeah, the price increases significantly starting April 1st. And it's not April Fools. We mean it in full seriousness. The price is going to be increased, and we want you to join. We are limited to how many, Rashad? How many doctors are? You may want to turn your mic on again. Unmute yourself.
Can you hear me?
Yeah.
Can you hear me?
Yep.
Hello?
Yeah, we can hear you.
Yeah, so we're limited to 30 doctors for this course. Dr. Chung, he registered, and he said when you go to the page, press apply for a discount. And if you have any issues registering, email us at help@surgicalmaster.com. we have 160 people still online. Frank, I want to do like a few questions and just short answers, like a powered question session, because we got a lot of questions. So, what do you do if the graft gets exposed? Just a quick answer. What's the management for that?
Removing the sharp edges, making an impression, giving to laboratory creating splint, and the patient charges with an anti-inflammatory gel 2 to 3 times per day for a couple of days, and usually then it heals.
Perfect. What about post-op pain? How many days from your experience?
So how long we have to do this treatment, you mean?
No, how many days are patients experiencing post-operative pain after you do the surgery?
No pain, like I said before. Maybe we have some discomforts because of the swelling, but no pain. Same, comparable to placing implants.
Excellent. What discs and screws do you use?
So I used several in the past. Like a Ustomid or a Stoma. We are working now also on something new. So soon you will see on Instagram and Facebook. So the discs are from Comet. Forgot about that. So the discs are from Comet. They're 8mm and 20mm. Yeah.
Okay. What about using sticky bone? It has white blood cells.
Sticky bone. So I know some colleagues who are using IPRF, for example, together with autogenous bone particles or MPM. So you can combine it with PRFs yet, but we want to do some studies with that.
Okay. How do you know the size of the screws to use?
Usually you don't need the big screws, so they can be around 1mm. That's enough, because you're not fixing huge blocks. You're just fixing these thin bone plates.
Excellent. Thank you, Frank. After thinning the block, roughly what should be the thickness of the final block?
So it should be that thin that you can fix it with a screw, but not too thick that the revascularization takes too long time. So it should be around 0.8 to 1mm.
How long is the average surgery?
So my surgery most of the time take a little bit longer, because I like to document my cases with video and pictures. So it really depends on